HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Associate Professor Andrew Vakulin on detecting and managing obstructive sleep apnea in primary care. Professor Vakulin, tell us about yourself.
Yes, I'm a senior researcher at Flinders University at the Flinders Health and Medical Research Institute Sleep Health Group. We're a large multidisciplinary team looking at all aspects of sleep health, and my particular research interest is looking at the impact of sleep disorders on daytime function, particularly in relation to operational performance, such as driving and accident risk.
And Andrew, today we are particularly looking at that very last topic about sleep disorders and motor vehicle accident risk. For us as GPs to understand this issue, can you just give us a context of how prevalent and how serious this problem is?
The prevalence estimates for obstructive sleep apnea have been rising over the last 15 to 20 years, particularly due to the way we measure sleep apnea and the way we quantify it, but also because they're closely linked to overweight and obesity. And so as our population ages and gains weight, and particularly in Western countries, the more prevalent we see obstructive sleep apnea. So current estimates is anywhere from 20% of the adult population. So 1 in 5 would have moderate to severe obstructive sleep apnea that warrants clinical evaluation.
With this group of people, and it's a very large group of people, it impacts on our daily living, but it impacts on our driving. So Andrew, what kind of figures and information do you have specifically on the impact of moderate and severe sleep apnea on driving performance?
There's been a fair bit of research effort over the years looking at impact on driving, both from a population perspective, so looking at actual accident rates, as well as experimental studies looking in a lab using driving simulators, and systematic reviews. There's been 2 or 3 systematic reviews in this area, essentially came to the same conclusion that if you have obstructive sleep apnea relative to the population without sleep apnea, you are 2.5 times at greater risk of having a motor vehicle accident.
When you say at risk of accidents, are you talking about minor parking issues or major accidents?
No, these are actual recorded traffic accidents. So this comes predominantly from population studies that are able to track, the actual accident has been recorded and reported through insurance registries and police records.
I'm tempted to ask, Andrew, whether or not there was a significant percentage of these people who were aware that they actually had an impairment in their driving because they're overtired. Or maybe I could ask the question, was there a lack of self-awareness that they had this issue and therefore had an accident and wondered how it happened?
Yeah, the self-awareness and perception of sleepiness while driving is an interesting topic, and it's gained quite a lot of research attention over the years. The current consensus in the literature is that people are generally aware of their state of fatigue and sleepiness. So we don't just drive and then suddenly 5 minutes later we're falling asleep. So there's a period during which people are able to be aware that they're getting tired, and there's certain behavioral symptoms, yawning and sort of nodding off. Just getting, people start opening windows or listening to the radio. They have certain countermeasures that people do. So those are all signs that you are fatigued and you should be either having a rest or having caffeine, engaging in some sort of countermeasures without continuing to drive. However, there is some evidence that in particular groups, such as sleep apnea, for example, or under conditions of sleep deprivation, for example, you may be less aware of how sleepy you are in comparison how much impairment you actually have. So you might be really impaired, but your level of self-awareness may still, indicate to you that you're okay to drive when you're actually not. but there's still a lot of work to do in that area. But certainly, the consensus is that we can't use awareness as a defense, for example, to say people, I just wasn't aware that I fell asleep.
You just brought up a very interesting topic here, because you mentioned that, yes, we have 20% of the adult population with obesity and sleep apnea. And you just brought up this sleep deprivation issue, which I'm afraid, tends to be in probably younger people and not necessarily obese, and they probably think they'll never die. So, I guess they get into accidents as well, and it might well be a sleep disorder because of quantity or a lack of quantity of sleep. How does your group view this problem?
Sleep deprivation and insufficient sleep, whether it's sleep disorder or it's self-inflicted in young people, I guess what we know is that people are they have a trait-like susceptibility to sleep loss. So it's something we believe people are born with. So one individual might be very vulnerable and susceptible to sleep loss or a sleep disorder if they have it. And so they tend to be the ones that actually feel quite sleepy and they report symptoms and they're impaired. But a lot of people are actually more resilient in a way in that it takes a lot longer for them and a lot greater sleep loss. And that's why, even though there are so many people out there with sleep apnea, 1 in 5, not everyone is crashing their cars, and clearly not all young people who are frequently sleep deprived, or everyone. So it's really, it's trying to identify the risk both in a sleep disorder population and more broadly as to how we can identify the risk early and how we can prioritize and mitigate the risk in those who are particularly vulnerable in that situation.
Going off to tangent, because I really understand this issue of sleep deprivation resilience. You mentioned when you're driving, you want to turn on the radio, put down the windows. I guess, resilience relying on caffeine and other sorts of things to keep us awake might be tools that we have learned along the way. But are there healthier ways of building sleep deprivation resilience that could be helpful?
That's the interesting thing is there's no strong evidence currently that it is something that you can teach yourself or learn to do. So, people that go into shift work eventually stick with shift work longer term are usually people who are able to either develop coping mechanisms, behavioral countermeasures, so that you tend to start to believe that you're better at coping with it. But from a objective perspective, we don't think people learn or get used to and actually perform better. So you're born with your susceptibility and it stays that way, but often people self-select in the different occupations. So if somebody is really impacted by sleep loss, they don't stick around in those positions that require them to be in sleep loss. And yeah, we don't tend to see that somebody who's really vulnerable can take steps to become resilient and vice versa. It changes through over your age, so sleep and your susceptibility does shift from younger to older age, but more or less it stays consistent, which is why we think it's really important to find these biomarkers to predict who's susceptible and who's not.
How's the work going with regards to the biomarkers for measuring susceptibility?
We're making good progress, and a lot of labs are focusing on this particular area. And there's certainly markers, both from a blood biological markers perspective, that can detect how long somebody's been awake, for example. So that's detecting state sleepiness, which would be important for fitness to drive or fitness for duty sort of testing. There are certainly behavioral measures, the ocular, using the eyes, eye movement and facial recognition, and lots of vehicle manufacturers do have technology in their cars already. So it's just trying to understand how that technology works. From a research perspective, yeah, we think that the ocular metrics are certainly promising. From my perspective and my research, I'm actually not just interested in detecting how sleepy you might be right now, but generally trying to, and it applies to primary care as well, as if there's a patient in front of you, how can you establish if that individual may be at risk, not necessarily now, but just generally determine their susceptibility. And the two concepts are quite different. One is trying to determine how much sleep you had in the last 24 hours. One is trying to determine if you did drive at 2 a.m. whenever, are you susceptible to falling asleep in those situations?
Two very important areas, of course, all of us as GPs would be very keen to learn more about. Andrew, when do you think you might come up with some findings?
We're publishing a few findings at the moment. So there's looking at brain activity through EEG. That's, gives us a proof of concept, and there are some technologies that can monitor your brain activity, while driving using technology, but it is not as deployable in the field to measure EEG while somebody's driving. So certainly looking at ocular measures where it's non-invasive and a person is able to drive their vehicle unimpaired. We're analysing and running studies at the moment. So we're hoping it won't be too long before we have some of those findings out.
Now coming to some practical issues for our listeners as GPs, 20% of the adult population being at risk of sleep deprivation of some sort from sleep apnea is a big number. And short of the patient saying, "Doc, I nearly fell asleep on the wheel," how rigorous should we or proactive should we be as GPs in chasing down patients at risk of motor vehicle accidents from sleep deprivation in a consult that has nothing to do with sleep?
Yeah, look, great question. And look, it's tricky. It's a combination of using the sort of established questionnaires that gauge sleep apnea and sleepiness. But if the patient is not there about sleep, it's trying to identify, if a patient does present with significant overweight, sort of middle-aged males tend to have more sleep apnea, but certainly female, middle-aged females will also be at higher risk of sleep apnea. And it's, if there are symptoms, hypertension and diabetes and those sort of problems, chronic conditions that GPs would typically deal with, if somebody's in front of you with those sort of problems, it's highly likely that they would score highly for sleep apnea if you did ask the questions and if you did evaluate it. And so I think it's, if you pick that up, particularly if a person appears to be fatigued and appears to be lethargic, even if they're talking about being tired, not in the context of complaining about sleep, you could use these tools like the OSA 50 questionnaire or the Berlin questionnaire, which are recommended as the tools to use in primary care setting. And they're more robust in terms of subjective report because they're looking at people's body weight and gender, things that people can't sort of have any recall bias. And if you score high on those, you're having a good indication that the person is very likely to have a level of sleep apnea that warrants attention. Particularly, it's the case in commercial drivers or people that have a commercial license. And typically, you won't get, there's issues with honesty and recall in terms of how sleepy they might feel, but at least if you can establish that they have a high risk for sleep apnea, I would recommend referring those patients for specialist review. For private drivers, it's really trying to get an honest answer out of them about their levels of sleepiness using the Epworth Sleepiness Scale, which is the typical gold standard questionnaire we use. And so if they have a high risk of sleep apnea and they're reporting to be sleepy, more than 16 points on the Epworth Sleepiness Scale, that would raise alarm bells, and the GP could either directly refer to a sleep study straight away with follow-up with a specialist, or they can refer them to a specialist straight up as well. But certainly GPs have the tools and the Medicare numbers to use directly for sleep assessment if they have worries about sleepiness and sleep apnea.
This episode is one of hundreds of informative and free clinical podcasts from HealthEd. Access the entire library through the HealthEd app for healthcare professionals, which you can download today from the App Store.
I'm just wondering, Andrew, what you think about the process whereby, as a busy GP, you see a patient who fits the phenotype that you described and they do look fatigued. And listen, mate, I'm running a bit short of time here. What about the fact that I say, listen, this is a really important questionnaire. Why don't you take it away and fill it up? And when I see you again, bring it back to me. And I make a note of that in my notes that the patient's taken away and Epworth sleepiness scale or something like that. Because the chances that we would just chase that person enough to think that they warrant a scoring assessment and then do the scores and then work out what to do, that is actually a fair amount of time done in the consult that, as I said earlier, may have nothing to do with sleep. And so should we as GPs pretty much just target every obese older people who look tired and give them an assessment sheet and says, please fill this up, it's important, and bring it back with you?
Look, absolutely. I would advocate that, yeah, you don't need to do it right there and then, but certainly if you have a suspicion that sleep apnea is likely, and it is, as you know, as you heard, highly prevalent, and you can do something about it, and that would help a lot of other chronic conditions that they might be suffering as well. So they might be there for diabetes or hypertension or mental health. It's something quite simple that they can take away with them. As you said, they can complete it, bring it back next appointment, and you can then decide whether to act on it or not. And you know, if they're low in their scoring and they're not sleepy, that's fine. They wouldn't meet criteria for a sleep study anyway. But if they do, you can refer on. And certainly our group are doing a lot of research now to translate primary care and based management of sleep apnea as well. So hopefully in the next few years, we'll actually have the tools for the GPs to be able to directly manage this sort of straightforward cases without having to refer and have long waiting lists and so on. So there'll be more tools available.
I'm really interested in that because at the moment, short of referring to a sleep physician, you know, and helping the patient to lose weight, which of course is a very tough gig, what else can we do?
Yeah, so there's been a number of randomized trials that were quite successful, both here in Australia, led by our team, and as well as overseas, that are essentially looking at, you know, primary care-based management of sleep apnea, including practice nurses. So these are specialist nurses. It's, you know, we know how busy GP clinics and GPs are, so nurses are essential in this model. But they all show that, you know, they're non-inferior results in GP-managed sleep apnea versus specialist care, and they're a lot more cost-effective and they work. So really now, in the last number of years, we've been looking at more of implementation trials. So we've got cluster randomized trials currently running, funded by NHMRC, led by our team, essentially implementing a simplified model of care for sleep apnea and also insomnia as a separate condition, to really equip GP practices with the tools and the knowledge and the resources they need to manage your straightforward cases, leaving the more complex cases for the specialist care, which is what we believe should be the case, you know, because there's so much sleep apnea out there. There's no way sleep specialists can deal with it all, and they should be dealing with the more complex cases like the high risk, you know, really high risk commercial drivers and so on. But the straightforward sleep apnea cases can and should be managed in primary care if it's properly resourced, and obviously hoping that the outcomes of our work will support and lead to governments subsidising, providing resources for that sort of model.
You've just got me very excited there, Andrew, because it's true that even in general practice, you know, I have patients who are morbidly obese with heart failure or nocturnal hypertension, which is ridiculously high. These are patients that I probably wouldn't be very happy to sit on. So I'm sure you will come up with a tool to help us to stratify our patients and refer the difficult ones and maintain or keep and manage the, if you like, the simple, less complicated ones. But are you talking about the fact that GPs in the future may be using CPAP machines instead of just specialists being the only ones to prescribe them? And if so, GPs will need to be taught all the parameters that we're aiming for, from AHIs and desaturations and number of events and what have you. So it's a large educational activity. Are you all planning to do something like that?
Yeah, look, we have recently completed a Centre for Research Excellence grant that went for 5 years, where we developed tools. So there is a sleep health resources for GPs already, and it's hosted by the Royal Australian College of GPs and the Australasian Sleep Association. So that's up and running and online. So GPs can already look and see a sort of gold standard management of sleep apnea and insomnia that's developed through specifically for primary care. But yes, what we are talking about is a simplified management. So we're not talking laboratory-based sleep studies or even home sleep studies that are full polysomnographies, but we're talking using level 2 and level 3 type sleep study devices, which are not currently, subsidized, but are overseas, and we're certainly building the evidence base to have more oxygenation based, so oxygen level simple devices similar to 24-hour ambulatory blood pressure sort of technology. People could take that, GPs could have that equipment, and with the right knowledge of being able to interpret it, they can certainly very accurately rule in sleep apnea and rule out sleep apnea based on that objective test. And then they could refer directly to CPAP or other type of management, mandibular advancement, split, weight loss, supine avoidance, and other sort of measures. And yeah, there's certainly guidelines, and those sleep resources that we develop would take GPs step by step as to appropriate ways to go. We're not there yet because it requires time and resources and nursing resources within a busy GP clinic. But as a research trial at the moment, if that's successful, we hope that would lead to more wider implementation in Australia.
I can't tell you how excited I am, because this problem, as you rightly defined, is hugely common, and that most of them are not actively treated, and that GPs tend to just refer and not even get close to any of these patients because we're not armed and taught what to do. In many ways, we are unskilled and de-skilled in this area, and we're very happy to not want to wander into it. But what you're saying is there is a potential that in the future, GPs can actually subspecialize in sleep disorders and the management of simple sleep disorders, and within the practice, actually develop a set of skills, like some GPs been good at women's health or pediatrics. You could actually target sleep issues as a legitimate subspecialty.
Absolutely, that's right, and that's certainly one of the key targets of the simplified models that we're looking at. If it's not applicable to everyone, to all GPs, it would be a specialized sort of GPs with a special interest that would take this on and would, if it's properly resourced and subsidized by Medicare, then those resources would flow to clinics with that specialty, and it would provide increased access to care and really help the stretched specialist care, where other GPs could be referring to these specialist GPs in a way who are trained in sleep health management. So yeah, that's sort of certainly one of the possibilities in the future.
I'm just going to ask you a question about where your research is going with regards to how it impacts general practice. As you look toward the future, there are lots of new things happening, like what we just spoke about, sleep subspecialty within general practice. Where do you see where we're going? What might be on offer? And what is the potential role in the future of the general practitioner in future settings with regards to sleep issues and driving?
I think the more it's sort of there's a lot of advocacy and lobbying and work in primary care, but broadly through the Australasian Sleep Association and the Sleep Health Foundation as well, that's trying to develop and raise awareness of sleep health and problems with sleep health at a population level, as well as specialist and clinic, primary care and tertiary care settings. And the more momentum that gets, so more people are aware about their sleep and their sleep health and the fact that they should do something if they're not having enough sleep, the more that would, of course, translate people presenting to GPs with sleep problems. And so we're trying to establish, the evidence base, but also their education needs, the guidelines, and the simplified models of care that could work in a primary care setting. And certainly our qualitative work, where we're consulting and talking to the GPs and the nurses and the practice managers, some of the early work we've done, there is a need. GPs acknowledge there's a gap, and that they could increase their scope of practice, particularly looking at insomnia management and sleep apnea. As you said, there are you just refer on. There's a lot of providers. So understanding how that fits and where that fits needs to be worked out. But there is definitely acceptance that there is a big demand and a big need for it. It's really just trying to work out how it works in practice in a very busy GP clinic. And a lot of GP clinics, they're not all the same. They're all different depending on where they are and the population they look after. But yeah, I see in sort of short term that there would be these specialist interested clinics and GPs that would drive that, and they would be sort of the drivers of change that would see others adopt it. Whether or not it'll be across the board in every GPs, it depends. To some degree it might, and maybe in some conditions it might, but certainly, the more we offer in terms of the solutions for sleep apnea and insomnia, and the more it's readily available and accessible to GP clinics, and the more I think it'll translate.
Andrew, I'm really thankful and excited that groups like yours are researching into how the treatment of common conditions not currently managed by GPs can be better managed by GPs, how we can stratify and refer the appropriate patients, how with the right help we can actually both identify and treat and manage the less complicated patients. I look forward to your work on biomarkers and ocular tools that tell us on how we can actually more accurately assess sleep disorders. So I just feel that you've just led me onto a work in progress that I'm hugely interested in, because there will be doctors, Andrew, who will be very keen to pick up sleep medicine as a subspecialty. But at the moment, there's not enough resources in teaching to upskill us to that point.
That's right. Look, and we're certainly working towards making that more accessible and more available.
Andrew, over to you for one last takeaway message.
Thank you, David. Look, I think sleep health is a major issue in terms of, apart from sleep apnea, there's all the other conditions. Insomnia, arguably, is even more common. It's very frequently mismanaged, mostly with sleeping medications, which is not the first line recommended treatment, which is cognitive behavioral therapy for insomnia. Again, it's not accessible. There's not enough psychologists or clinicians that are able to deliver it. So we're making progress in providing options other than sleeping medications for patients with insomnia, and GPs, I think, are receptive to that approach. And so the more awareness we raise for sleep health, the more there'll be a need. And so I feel that even though at the moment it's not widely taken up by GP practices, as time goes on and as the population and the government recognise that sleep health is an important pillar, the third pillar of health, alongside with diet and exercise, then it would become part of the sort of health framework that the government would get behind, and I would think that would lead to sort of systemic change in our health system.
Andrew, I thank you for your time, and I look forward to speaking to you in the future when you have more data to present to us.
No worries, David. Thank you for the opportunity.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.